There's a report out very recently citing that Canada's the second best healthcare system in the world. The second best healthcare system in the world. The second best healthcare system in the world.
We begin tonight with the agonizing pain patients are facing as wait times for surgeries and diagnostic tests grow across the country.
Canada has a severe shortage of family doctors, with over 6 million adults in Canada saying they don't have regular access to a family doctor.
Every person who waits in one way or another is suffering. I've seen wait times lead directly to people dying, including children.
Helping my health issues, because I already waited 7 years. Can you imagine? 2 more just to see the specialist, and then 2 more to get the procedure?
We're all proud to be Canadian, but I'm not proud of my healthcare anymore.
There's this phrase that I think is criminal, and it's Canada has the best healthcare system in the world. Well, it's actually a lie.
We've seen stories like this for years in Canada, and they're getting worse. Today we're going to talk about how we can actually improve Canada's universal healthcare system. We're going to talk about 4 proven solutions that can improve access for patients while reducing patient suffering. Plus, we're going to talk about a 5th idea that might just surprise you. Before we look at solutions to fix the healthcare system, let's look at the big picture. And I want to stress this right at the beginning. Every single day in this country, there are people that have very positive experiences with the healthcare system, and that's great. There are many good doctors and nurses and other healthcare staff who try their best every single day. But the reality is, there's too many patients that are falling between the cracks. Far too often, Canadians face long waiting periods to get a family doctor. They face long wait times at walk-in clinics and emergency rooms. They face long wait times to meet with a specialist, and even longer to actually receive surgery. These long wait times can result in anxiety, depression, addiction, and social isolation. Some patients even die while waiting for surgery. Retired Ontario nurse Judy Anderson told us how she has lost 2 daughters due to long wait times in the healthcare system. In both cases, the hospitals called to schedule surgery after her daughter had passed away.
I remember answering the phone and somebody on the other end saying, this is the cath lab calling from Scarborough. We're looking for somebody named Shannon Anderson. And I said, excuse me, like, you know, what are you talking about? Well, she missed her appointment for the 9th of March. We have it all set up. She's coming in. She's going to have the cardioversion. I really lost it on the phone. I just said, you have to be kidding me. She died like 5 days ago.
This is not a unique problem. In Quebec, the healthcare system phoned patient Michel Houle to schedule his heart surgery 4 months after he died. In Alberta, patient Jerry Dunham died during COVID after his pacemaker surgery was postponed. Sadly, these types of patient stories are too common in Canada. Government data shows that from April 2022 to March 2023, so over a 1-year period, over 17,000 Canadians died while waiting for various surgeries and diagnostic scans. Many of these patients would have suffered with pain while waiting for hip and knee operations, or struggled with cloudy vision while waiting for cataract surgery. This data would also include cases where patients died as a result of not receiving care in time. For example, data from Ontario Health shows that 931 patients died over the past decade while waiting for cardiac surgery. 26% of those patients died after waiting longer than the recommended time frame. Some people blame COVID for Canada's healthcare troubles, but this was a growing problem before the pandemic. Look at this data from Ontario Health that shows a steady rise in patients dying while waiting for MRIs and CT scans. You can see this increase began long before the pandemic. An important question to ask is this: is it normal to see so much patient suffering in a developed country like Canada? The answer is no. So how could all this be happening in Canada? Isn't our universal healthcare system uniquely Canadian? Isn't it supposed to be one of the best in the world? The truth is, Canada is not the only country in the world with a universal system. Lots of countries have universal healthcare, systems where everyone is covered, just like Canada does. When patients in those countries receive something like a heart operation or a knee operation, they don't face a massive bill like you hear about in the United States. Their universal healthcare system covers the cost of the procedure, or the system pays for most of it. Unless, of course, the patient has decided to pay for private care. The reality is, our universal healthcare system doesn't stack up well when compared with other universal healthcare systems around the world. Consider research by the Commonwealth Fund, a healthcare research foundation that some would describe as left of center. Their 2021 report looked at 11 countries' healthcare systems and examined things like access to care, patient outcomes, and efficiency. They ranked Canada second last out of 11 countries. Research by the Commonwealth Fund also shows that Canada had the longest wait times to see a specialist and to receive surgery. For an alternative perspective, the Fraser Institute is a think tank that's based in Canada. They too routinely look at how our system compares with other universal healthcare systems. Some would describe the Fraser Institute as right of center, yet they found the same thing. Their most recent report concluded that Canada ranked near the bottom when it came to things like the number of doctors, hospital beds, and wait times. So international studies by both the left and the right have come to the same conclusion, and that is that our universal healthcare system is not performing well. So this begs the question, are we not spending enough money on healthcare? Is the lack of funding the problem? The answer might surprise you. For 30 years, we've seen governments of all political stripes in Canada, Liberal, Conservative, NDP. They've increased healthcare spending by billions and billions of dollars. In 1993, government spent an average of $1,688 per person on healthcare in Canada. 30 years later, as of 2023, government spending had increased to $5,748 per person. That increase in spending is more than double the rate of inflation. Over the same time period, wait times for surgery increased from 9 weeks to nearly 28 weeks. Despite a massive increase in spending, wait times grew even longer in Canada. And it's not that Canada was simply catching up to what other nations spend on healthcare. According to the Canadian Institute for Health Information, Canada is among the highest spenders on healthcare in the developed world. Throwing money at the system just simply hasn't worked. The problem is the system itself is broken.
I had to be resuscitated a number of times throughout the initial operation. Probably because of that, and the fact that I had such a profound infection as well with the sepsis, it was very difficult for me during the ICU.
That was BC patient Joan Hama talking about how her colon ruptured after she had to wait double the recommended wait time for a colonoscopy. Not only did she have to be resuscitated multiple times at the hospital, her family was even called in to say their final goodbyes. Her situation could have been avoided entirely. So what can be done to improve the system and prevent long wait times like Joan experienced? Well, consider how hospitals are funded. Each year, provincial politicians decide how much funding to give each hospital. Governments basically tell them, here's $200 million or whatever the amount is. And then they ask them to do their best to help patients. This approach is known as block funding, and the rest of the world has moved away from this model. Many experts argue that this is not effective. It provides no accountability and no incentive for hospitals to help as many patients as possible. It can also result in hospital administrators worrying that they're going to run out of money rather than focusing on helping patients. This approach can lead to hospitals wasting too much money on bureaucracy and administration, or spending money on activities that don't help patients. For example, the Windsor Hospital in Ontario has lost $2 million by running its own Tim Hortons franchise. Yes, tax dollars given to the hospital to help patients were instead used to pay for double-doubles and donuts for the public. Many healthcare experts, including the Fraser Institute and Montreal Economic Institute, have long recommended a policy that incentivizes hospitals to focus on helping as many patients as possible. It's an approach known as activity-based funding, and it's used widely in European countries. For example, if a hospital performs a knee operation on a patient, it might receive, say, $18,000. If a hospital helps deliver a baby, it might receive, say, $8,000. This means that when a patient needs help, the hospital won't ignore their phone calls or see them as a drain on the budget. The hospital will see them as a customer that they want to help, because then the hospital receives more money. Ultimately, this approach improves access to healthcare. We spoke to Crystal Wittevrangle at the Montreal Economic Institute about Quebec's experience using activity-based funding.
Quebec uses activity-based funding for a number of surgical programs. They've done so since about 2016. They started on a widespread basis. They've had great successes with this being implemented in stages, so much so that their recent budget has really extended it to all surgeries and moving towards including it in medicine, emergency rooms, and a few other programs. Most other OECD countries with high-performing universal systems incorporate activity-based funding, at least in some proportion. Australia is a great example. They use it widespread across entire hospitals and, all medical programs within those hospitals. Sweden, England, Germany, you name it, they are all incorporating activity-based funding.
British Columbia has actually experimented with this policy in the past in the Vancouver Coastal Health Authority, and they found it had a positive effect. We spoke with their former board chair, who has since joined our board.
We activated activity-based funding inside our system, and it made a profound difference. And it profoundly changed the decision-making of everyone, from the nurses in the ward to how the physicians access their patients and how they perform their work in their ORs. So everybody shared in that benefit. If one particular division of surgery performed very, very well, they actually got to keep the extra money to either hire more nurses, to hire some extra technicians, to maybe invest in some equipment. That enabled them to actually think about, how can we take 8 surgeries a day and make it 12? How can we move the 12 to 16? Better for the patients, better for the system, and better for their work environment.
If British Columbia had this approach in place in Kelowna, it's possible that Joan wouldn't have had to wait so long for her colonoscopy. The healthcare system would have been incentivized to complete more procedures, perhaps by doing things like doing more procedures in the evenings or on the weekends.
My surgeon provided an affidavit as well, and he is of the opinion that if I had the colonoscopy within the 8-week time period that they recommend, I wouldn't have had to go through any of what I did.
We spoke with Dr. Brian Day, a former president of the Canadian Medical Association, about this policy.
When you have a state system run as a monopoly, the hospitals, and this applies to all hospitals in Canada, are given block funding or global budgets once a year, and that's for the administration, which is excessive, and for treating patients and buying equipment and so on. Every patient, therefore, who goes to a public hospital, whether it's emergency or whether it's for surgery, is using up the annual revenue. So the last thing the chief financial officer of a hospital wants is patients, because they use up the revenue. So that's why there are lineups, and that's why governments ration access to healthcare. And the BC Appeal Court in our constitutional trial came out and said it is government policy to ration access to healthcare in order to save money. And they do it by not treating patients.
Dr. James Stone is a surgeon in British Columbia.
Instead of giving a lump sum money to a health authority and say, here, deal with as many patients as you can, say, okay, this $10,000 is going to be for hip replacement. It's attached to that patient. If the hospital does that, they get that $10,000. If they don't do it, they don't get anything, or they get minimal kind of administrative fee. If the money followed the patient, you'd see a change. You'd see a change. You'd see where the efficiencies would come in, would not be in, things that don't matter, like, we're changing our computer system again.
While we've seen some examples of activity-based funding working well in Canada, our country's been slow to adopt this model. The majority of provinces have yet to use this policy solution, which could actually help patients.
So when you are facing cancer, you don't know what day it is that cancer moves. You don't know if it was yesterday, you don't know if it was last month, you don't know if it's tomorrow, you don't know. So every day is really critical.
Beginning in her 40s, Leah regularly went for mammograms, but because she had what are classified as dense breasts, she was referred for an ultrasound as well. This is a diagnostic scan that can help detect cancer when mammograms can't. Eventually, she was diagnosed with cancer and went through a brutal battle with the horrible disease. Giving cancer a year head start no doubt contributed to Leah having a harder fight than necessary, including having her breasts removed. One way that governments can reduce wait times for patients like Leah is by taking ideology out of healthcare. In countries like Sweden, the government will contract with anyone who can provide quality healthcare in a timely manner. It doesn't matter if it's another government health facility, a nonprofit clinic, or private clinic. Their government will partner with them as long as they can help patients. In Canada, this happens when you visit your family doctor's office, which is actually a private business. You walk in, show your government health card, meet with your family doctor, and walk out. You don't pay a bill. The government pays your doctor's office for your visit with tax dollars. Many provincial governments in Canada have used this same approach with services like blood testing, x-rays, and sometimes simple surgeries. You may have gone for an x-ray or a blood test at a private clinic, but didn't even know it. But the government has contracted that clinic to provide you with that service. While we see this approach used on a limited basis in Canada, it should be used more. It could help reduce wait times for surgeries and to meet with a specialist. Consider this innovative example for British Columbia. In Victoria, a company called Rebalance MD has helped reduce wait times dramatically when it comes to patients needing surgeries like knee and hip operations. Rebalance handles the first waiting period that a patient experiences when they need surgery. So this is from the time your family doctor refers you to meet with a specialist, and you actually meet with that specialist and decide you'd like to proceed with surgery. When a patient visits their clinic, the staff organize the patient's entire journey. So 1 week you might be in one room for an ultrasound, a week later you're in a different room meeting with a specialist, but it's all in the same building. Ultimately, the government's partnership with Rebalance has cut wait times tremendously for patients waiting for hip, knee, and other orthopedic surgeries. Stefan Fletcher is the CEO at Rebalance.
Before Rebalance, the wait time for consultation was anywhere from 9 to 18 months. After Rebalance, the wait time went down to anywhere from 8 to 12 weeks.
Before Rebalance, there was a collection of surgeons working in a less than coordinated manner. There were 4 offices in town with referrals going to multiple sources, from multiple sources, and really just a chaotic environment in terms of getting in the door for patients. Really not a very satisfying environment to work in. I'd come from fellowships overseas where they're much more organized because there's a private system as well. It reeked of amateurish, really, because there was no coordination.
This obviously begs the question. If Rebalance has done such a good job at reducing the first waiting period that a patient experiences, then why doesn't the government partner with Rebalance or some other partner to reduce the second waiting period? This is the time from when a patient decides they're going to proceed with surgery until the time they actually receive it. In Canada, whether or not governments partner with non-government health providers for things like diagnostic scans and surgeries, it's completely arbitrary and differs province by province. But it has been shown to work in many cases. For instance, Ontario's auditor noted in her 2014 annual report that certain services, such as MRIs, dialysis, and colonoscopies, were about 20 to 40% less expensive if delivered in community clinics, including independent health facilities, rather than in hospitals. In Saskatchewan, the government noted that they're actually saving money by partnering with private surgical clinics. They note, assessments showed that the difference between per procedure costs in public hospitals and private surgical centers are roughly 35% in plastic surgery and general surgery day procedures, and up to 45% in orthopedic day procedures. But it's not just Canada that uses this approach. Last year, secondstreet.org went to Sweden, and we saw 2 government hospitals located just a few kilometers apart. The difference, though, was that the government hired a private company to manage one of the hospitals. That hospital actually delivered the same quality of care for patients in the public system, it just did it for a lower cost. Those savings could then be used to pay for even more surgeries and health services for Swedish patients. Nadim Esmail from the Fraser Institute told us that many other European countries use this approach.
Spain's program to reduce waiting lists that was very successful relied on private sector providers. The United Kingdom, as part of their program to reduce wait time successfully, has relied on private providers. And when we look at some of the developed world's most successful universal access healthcare systems with the best healthcare outcomes or the best access, we find in 100% of them, private providers delivering universal access healthcare.
Privately delivered, publicly paid services is one way to increase access to treatment for Canadians. I think that doing so really is just providing more options across the board. Again, these are publicly paid services, so it's no different than seeing your family doctor who is privately providing a publicly paid service. It's just utilizing more resources outside of the typical way of doing it.
While we're seeing governments partner more with private clinics across Canada, we're also seeing the opposite happen. In BC, for example, the government will not contract with any MRI clinics that also allow patients to pay privately. The government wants exclusive control of their business. It's a very strange ideological position, something governments don't do with other businesses. This would be like the government telling Staples that they're not going to buy paper from them anymore because Staples also sells paper to the public. As a result of the BC government's actions, perfectly good MRI machines are sitting unused instead of helping patients. One owner of an MRI machine in BC told secondstreet.org that he could double the amount of scans he does each year if the government wanted to contract with him. The government won't do this, though. They're leaving patients on waiting lists instead of contracting with this clinic. The government is putting ideology ahead of helping patients, which results in longer wait times. Now, to be clear, governments can still sign a bad deal with a private clinic, whether it's for a diagnostic scan, surgery, or something else. But if governments do a good job shopping around and they structure a good contract, this is an option that can definitely help a lot of patients. And it's something that should always be explored.
I used to walk with a friend of mine, and finally I just said, I can't do this. And I kept harassing the doctor because I wanted to get something done. I was bone on bone. There was nothing left between the bones. So the upper and lower leg bones were doing this, and it just becomes impossible to walk.
Jerry Agar is from Toronto, Ontario, and spent a year waiting for knee surgery. As he noted, it greatly affected his quality of life. Not only did his knee pain restrict his ability to go walking with friends, he also couldn't use his motorcycle, and it affected his relationships with those around him.
When you have elective surgery, like my situation, they elect to stall you off as long as they possibly can, and the condition gets worse. What kind of a healthcare system is that?
It's no secret there are thousands of patients like Jerry in Canada. Patients with chronic pain while waiting for knee and hip operations, back surgeries, and more. A policy change that could help reduce wait times for patients like Jerry comes from the European Union, and it's known as the Cross-Border Directive. In simple terms, EU patients are allowed to go to another EU country, pay for surgery, and then be reimbursed by their home government. Reimbursements cover up to the same amount their home country would have spent to provide the surgery locally. For example, imagine Gustav, a patient in Denmark who is facing 4 months to get knee surgery. In the meantime, he's in a lot of pain and he's off work. If he waits in Denmark for 4 months, it might cost the government, say, 12,000 euros to provide surgery. Instead of waiting, if Gustav goes next door to Germany, he might be able to receive surgery next week. As long as the surgery costs less than 12,000 euros, Gustav's only costs are for his travel and accommodations. Conversely, if surgery costs more than what the Danish government pays, then Gustav pays the difference. Ultimately, this policy gives patients in the EU thousands of options instead of just having to wait for the government to provide care locally. If Canada copied the EU policy, we could give patients access to care in other provinces, next door to the United States, Europe, Japan, and so forth. We could give Canadian patients thousands of options so that they could get a hip or knee done in a couple of weeks instead of having to wait a year or two. Think about all the patient suffering that could be avoided. Fewer patients getting addicted to painkillers. Fewer people gaining weight because moving around causes too much pain. Fewer grandparents who are unable to pick up their grandkids because they're in pain while waiting for surgery. Think about how this could help patients' wallets. Right now, thousands of patients can't work because they're stuck on waiting lists, or maybe they're not as productive at work. Research by the Fraser Institute found that patients on waiting lists in Canada lost an average of nearly $3,000 in wages and productivity in 2023. That doesn't include the value of their evenings and weekends, which are also affected. The cross-border directive policy could help these patients, but it could also help patients who don't want to travel for surgery. After all, they get to move up a spot in line each time someone ahead of them in line does decide that they want to travel for surgery.
This pain, it engulfs you. I slipped into a very, very dark place. You know, I have a real appreciation for depression now and the darkness that revolves around that. I'm usually a pretty upbeat, happy, outgoing person, but I've seen the true power of chronic pain and the way it can take you over.
That was Alberta patient Jeff Krischel talking about his brutal wait for back surgery. Jeff lives just outside of Edmonton and stayed in shape his whole life, but eventually he developed back problems and required surgery. He was told that it would take at least a year to receive surgery in the public system. You see, in Canada, unlike any other service, the government deliberately rations access to health care. Jeff was out of luck. He would have to wait until the following year for surgery. In the meantime, he was in serious pain. So he looked across Canada at non-government options and found that there was just one clinic that offered the type of surgery that he needed. It seemed perfect for Jeff because it was just down the highway in Calgary. The only problem was that when he phoned the clinic, they told him that government rules prevent them from providing private surgery to patients in Alberta.
I think when I was told that I couldn't get this procedure in Calgary, right down the road from me, that's when I got angry. But I actually talked to a few people there. I'm saying, look, you guys are the only place in Canada. You're telling me I have to move to BC, get my BC citizenship or Saskatchewan, and then I'm able to come back to Alberta to get this done? It makes no sense at all.
Ultimately, Jeff flew all the way down to Atlanta in the United States. Now, we generally find this type of ban all across Canada where patients are not allowed to pay for medically necessary surgeries in their own province. The exception to this is Quebec. In Quebec, patients have a choice. They can use their public system or they can pay for surgery at private clinics in the province. Now, Quebec patients have this right because of a 2005 Supreme Court ruling. They famously noted, access to a waiting list is not access to health care. This decision opened up access to health care for Quebec patients. The Supreme Court has refused to give patients in the rest of the country this same right. Dr. Brian Day spent over a decade fighting in BC's court system to get the same choice for patients outside of Quebec. But after 14 years, his case finally got all the way up to the Supreme Court, but the court simply refused to hear his case.
The judges of the Supreme Court of Canada refused to hear our case. Those judges are exempt from the laws that they say should apply to everybody else. I have had checks from the federal government paying for surgery and assessments of judges. Other groups exempt are like Canadian Armed Forces and, of course, everybody who lives outside of your province. It's bizarre that residents of another province have more rights in your province than the residents do.
So which other countries have bans on private treatment? Here's a list of countries with universal healthcare systems that have bans on private care like Canada does. And here's a list of countries with universal healthcare systems that don't have these types of bans. No other developed country does what Canada does because it harms patients. Think about how it affected Jeff. Instead of paying just for the cost of surgery, Jeff had to pay for a flight for him and his wife all the way to Atlanta. He had to pay for a hotel and more. While he recovered, other family members couldn't visit him. If he was allowed to go to Calgary, it would have cost less, and his daughters and other family members could have been by his side. And if it costs less, then more patients could access this option. When governments give patients a choice between public and private options, most patients will still use the public system, but some will use private options, and when that happens, that will help take some of the pressure off of the public system. But we shouldn't think of private options, though, as necessarily coming with a big bill for surgery. Canada could do what other countries do and allow extended health insurance options, just like you might have insurance coverage for dental and eye care. So you would pay a small amount each month, and if you needed surgery, then you could use your insurance if you didn't want to wait for the public system. Allowing patients to pay for private surgery or purchase extended health insurance is one way that we could grow Canada's healthcare sector without requiring tax dollars. Obviously, not everyone likes this idea. It would mean taking control away from those who benefit from the monopoly we have right now.
We strongly feel that this will not benefit anyone but the corporations that are putting these clinics into practice.
Some in Canada fearmonger about allowing private care. They claim the sky would fall, that private facilities would steal all the healthcare staff. But ask yourself this: how does Sweden do it? How does France do it? How does Australia do it? These countries all have better performing universal healthcare systems when compared with Canada, and they all give patients this option, so we know it can be done.
When we look at countries that have staff that perform in both the public sector and the private sector, often there's regulatory mechanisms in place to keep things at an even keel, whether that's a limit on the amount of time spent or what pay they can receive from the private sector. There's ways to mitigate this.
There are spare physician resources in Canada. We know we have unemployed, fully trained physicians. We know we have physicians who cannot get as much surgical time as they're willing to provide, so they use that time as leisure for other services. That spare capacity can be used in the private parallel sector. We also know there are any number of other health professionals who can't work in the public system for whatever reason, whether it's the employment agreements, whether it's the particular pay or the particular conditions, who under more flexible conditions in a private facility might be willing to come and provide their services.
Nadim's point is important. Consider this. Using data from the Michigan State Licensing Board, SecondStreet.org was able to calculate that there are 1,887 nurses that live in Canada but get up each day and cross the border to work in Michigan. When we surveyed these nurses, we found that they didn't want to work in the healthcare system in Canada. It wasn't very appealing to them. They had concerns about not getting predictable hours, the availability of full-time employment and compensation. Imagine if there was more choice for those healthcare workers. Instead of choosing between working for the government system or leaving for Detroit, perhaps they might work at a nonprofit or private clinic in Ontario. This is one way that we can grow our healthcare sector in Canada. We actually heard this point when we were talking with health officials in Sweden. They noted quite simply that when you have more health facilities, you end up with more people working in healthcare, and that improves access. The 4 policy options that we've examined can improve the healthcare system and increase the number of options available to patients. That's the supply side of healthcare. But what about demand? There is a huge opportunity for Canada to reduce pressure on our healthcare system by helping Canadians live healthier lives. Consider these 3 diseases. The Heart and Stroke Foundation notes that up to 80% of premature heart disease and stroke can be prevented through your life habits, such as eating a healthy diet and being physically active. The Canadian Cancer Society notes about 4 in 10 cancer cases can be prevented through healthy living and policies that protect the health of Canadians. Finally, Statistics Canada notes that about 90% of diabetes cases in the country can be avoided by making lifestyle changes. To be clear, many Canadians have health problems that are genetic. You can't really prevent them. But there is an enormous opportunity to ease the pressure on our healthcare system through a shift towards healthier living. So what can be done? Well, this is obviously a complicated issue, but we do find some similarities when it comes to examining the 3 major diseases that we just looked at. For example, better diets and more exercise can help reduce the risk. Now, no one wants the government knocking on your door at 6 a.m. telling you it's time to go for a run. We don't want the government micromanaging our lives. But Sweden has done something interesting for 20 years to encourage exercise. Swedish doctors have been giving patients written prescriptions to exercise more. If a doctor concludes that a patient needs more exercise, and if the patient wants help coming up with an exercise schedule, then the patient will meet with medical staff and come up with a plan that works for them. If a patient likes skating, then maybe that's part of their plan. Alternatively, if a patient likes walking, then maybe that is built into their plan. What Sweden has found is that patients will follow their exercise prescriptions at about the same rate that they follow prescriptions given for medication. One study found that this approach helped reduce patients' blood pressure, body weight, and cholesterol, among other positive changes. Maybe something similar could be done in Canada. An alternative approach would be for governments to reward employers that have healthy living programs. For example, some plans will cover gym memberships, nutritionists, and personal trainers. Ultimately, healthy employees are less sick and more productive, but they also require fewer health services from the government. Considering what's at stake, we shouldn't be afraid to try some pilot projects and figure out ways to prevent some of the strain on the healthcare system in the first place.
And here today in Ontario is a truly historic announcement of $3.1 billion that's going to have a huge difference. Huge difference. Huge difference.
For decades, governments have simply thrown money at the healthcare system and hoped for the best. But obviously this approach hasn't worked because the situation has gotten worse. It's immoral to continue to let patients die on waiting lists or spend years suffering in pain while waiting for things like knee and hip operations. Polls show Canadians are ready to try something new. In 2024, polling company Leger found that 91% of Canadians believe the system needs to change, while only 5% thought the solution was more money. Fortunately, we can keep what Canadians love, and that is the idea of universal healthcare where everyone's covered. As we have shown, other countries have better performing universal healthcare systems than Canada, so we know it can be done. If we copy what they're doing right, then we can achieve better results too. Giving patients more choice and more partnerships in the healthcare system can reduce wait times and improve results. So what's the holdup? Well, it's actually our politicians. Right now, they control access to healthcare. They're in complete control. Unfortunately, we're seeing governments continue to stifle many reforms that could help. The federal government is cutting funding to provinces that allow patients to pay for a private MRI scan. Again, no other developed country does this. The Ontario government even wants to stop patients from being able to pay for appointments with nurse practitioners in non-government clinics. Again, no other country does this. In BC, the government let patients smoke meth in hospitals, but yet they banned other patients from paying for private care that can help. Their government doesn't exactly have sound judgment.
The hypocrisy knows no bounds amongst politicians with respect to healthcare. If they had to get in line along with everybody else, maybe things would change.
Fundamentally, we need a new approach in healthcare. Canada is a country with 10 provinces. Each province should try a new initiative in healthcare. And if something works, then other provinces should copy it. We shouldn't be afraid to try new initiatives when it comes to healthcare. Think about this. Where will our country be in 10 or 20 years if we don't make changes in healthcare and try new things?